Hello and welcome to our first in the series of quick QI webinars, where we're really going to provide a bit of an overview and an introduction to the model for improvement and how the model can be applied to your work to tackle problems or opportunities to make service even better. So this is going to be the first, and it's going to focus on building a quality improvement team. First, setting off on that journey, you obviously want to have a good team working with you, and that's where we're going to focus today. The broadcast will be done by myself, Michael Dunn, from the Excellence Through Quality Improvement project, as well as one of our coaches, Anna Mugimba, who works very closely with quality improvement teams and will be providing her insight. So on today's agenda, we're going to talk about what is E-QIP, this initiative that I mentioned, the Excellence Through Quality Improvement project. We're going to talk about the model for improvement, which is really our set of tools and methods to do quality improvement work. We're going to talk about the project charter and why this is important. We're going to detail team roles, keeping in mind that when we set down the path to do a quality improvement project, we really want to have multiple people on our team with different roles and backgrounds to make our team successful. And we're going to share some important considerations when we are creating our project team. So the Excellence Through Quality Improvement project, or E-QIP, is a partnership project between Addictions and Mental Health Ontario, the Canadian Mental Health Association Ontario Division, and Health Quality Ontario, the province's leader in quality improvement work. And E-QIP is a project that's really designed to support the community mental health and addiction sector in taking on and continually doing quality improvement work. And to do that, we offer a menu of services and supports to the sector, including things like quality improvement and data coaching, education and webinars such as this session, and a collaborative community of practice. And it's really based on our sector's existing commitment to provide high quality, person-centered care to individuals and families. When we speak about quality improvement in healthcare, and in particular the community mental health and addiction sector, what we're really talking about is a systematic approach to making changes that will lead to better client outcomes or better health, stronger system performance, or better care for folks when they come into the system, and enhanced professional development to support our workers and our staff who work in this field, recognizing that it's a difficult, often challenging area to work in, and we want to be continually supporting and building new skills and growing as the research and treatments also grow. And it draws upon the combined and continuous effort of all stakeholders within our health system. So healthcare professionals, clients and their families, researchers, planners, educators, to make and sustain quality improvements. And that really is the crux of what we call the quadruple aim. And you'll see that on the right side of your screen. And that is what I spoke of. It's better care for individuals, for better health for our population. If we're providing excellent care, hopefully people are going to be healthier and come into the system less often. And we want to also, as I mentioned, support our providers and our staff with the tools that they need. And hopefully we do this through as low cost or as efficient as possible as well. And to help get us there as a health system, we talk about domains of quality. And those are the things that our clients and our families who receive service tell us are important. Those things that speak to quality care. And those domains that by improving them, we're hopefully going to achieve that quadruple aim. And then on the far left, you'll see the model for improvement. And this is really where we're focused today. And it is the practical tools that we can all take and use that will help us to make improvements on those domains of quality. So for example, if I want my organization or my local system to be as safe as possible, I have tools within that model for improvement to look at how well we're doing and how we can improve, and then to test improvements. And that model for improvement is really focused on answering 3 questions and then using what we call plan, do, study, act cycles. So the 3 questions are, what are we trying to accomplish? Which speaks to that aim. Where do we ultimately want to go? If we're going to, let's say, improve safety, what is that going to look like? And by how much do we want to improve, and for whom? Our second question is, how will we know that a change is an improvement? It's great to say that something's improved, but we want to know that it's an improvement and not just a change, which encourages us and kind of forces us to measure what it is that we do. And lastly, what change can we make that will result in an improvement? So thinking of those first 2 questions, what changes can we realistically, practically make within our scope that will help move us along towards that improvement? And then whatever changes we make, we want to test through rapid cycle, plan, do, study, act, or PDSA cycles. Instead of going full implementation, starting small, testing within maybe one location, one shift, one program, to see if those changes are in fact an improvement. Today we're going to walk through a quality case example to help show the application of the quality improvement tools and principles that we were talking about. And the case example takes place at LiveWell Recovery Services. And so this example is completely fictional, and the case centers around a quality issue that impacts the clients of our fictitious LiveWell Recovery Services, which is a community-based mental health and addictions agency. The agency serves a diverse population in a mid-sized Ontario town with a population of about 100,000 people. It has 3 sites across the town, and it serves individuals living in both the city center as well as the suburbs and in rural communities. And complexities of clients are continually increasing, but LiveWell Recovery Services has a wide range of services that can accommodate a range of needs of clients requiring mental health and addiction support. They've experienced long-standing access issues into their intensive case management program. So they have made access into their intensive case management program a priority through their strategic planning process, as the wait time into care is clearly a source of frustration and dissatisfaction with their clients, and demonstrated through survey and focus group results. The intensive case management program manager looked at the wait time data for the past 2 years, which showed a steady increase in wait times into the program over time. At present, individuals that are referred into the program are waiting on average 108 days from the point of referral to service initiation. The data of referral into the program is documented through their client management software and is defined as the date that the referral source, that is either a primary care provider, community partner, or the potential client family member themselves, first makes contact with LiveWell Recovery Services staff requesting an assessment for an individual. And so here's a graph of what that data looks like. This is a run chart, which we'll discuss in detail on future QI webinar sessions. But as you can see, that blue line represents the number of days waiting for intensive case management service. And you'll see that over time, it's been steadily increasing all the way up until our current status of 108 days of wait. So with that, I'm going to hand it over to Anna, who's going to walk us through looking at our formation of our team. Anna?
Thank you, Mike. Now, if you guys look at this image on the screen, the top you'll see that we're going to go through the foundations to QI stages, and we're going to obviously show you tools. The first step that we want to do in the model of improvement and preparing for QI is look at the project charter as well as the team composition. So this is an image of one of our tools, which is the project charter. And I want to just speak to it a little bit quickly so that everybody understands what's on here. The project charter, it enables your team to succinctly demonstrate not only your understanding of the problem you're trying to solve or the opportunity you're looking to create, but it also specifies the boundaries, what the boundaries are, who's on your team, and what potential barriers you might encounter. So why do we use Project Charter? It establishes the scope of the project and ensures that the right team members are involved. It establishes a common understanding of the aims, measures, and a plan for the project. It keeps the team on track and recognizes the progress and milestones, and avoids common pitfalls such as goal creep, measurement avoidance, and loss of focus or momentum. And lastly, and even really important, it communicates effectively with the stakeholders and leadership of others about your QI project. Now, one thing I'd like to stress is that the project charter will continue to evolve as you work through your QI project. So how it starts off is not necessarily how it ends. It's something that, it's a document that you go back and you want to make sure that you edit and change, but it's always a good place. You might have several versions of your project charter, but it's always a good place for the team to go back and see kind of where the project is and what adjustments have been made in order for them to progress forward. So the first thing we're going to talk about is the team roles. And as you can see, there's a space on the project charter at the top left of the document. So establishing who's on your team is really an important step. So here is a list of the QI team roles, and I'm just going to go through them one by one. The executive sponsor is a person who's a part of the organization. They tend to be a champion and advocate for the QI work, and they're involved in the startup, design, and implementation of the project. They help ensure that the project is aligned with the organization's strategy, and they also have a significant role in resources, providing resources that the project needs and the support for all the work that the QI team will do. The next role is the QI team lead, and this person is responsible for the logistics, meetings, schedules, and to-do list for the project. They don't have to be the one doing all the work, but they facilitate the work being done. Next is a process owner. This person is responsible for the process you are trying to improve and has the ability or can get the ability to enable the process to change. The improvement advisor, if you are so fortunate enough to have someone at your organization who has some experience in quality improvement, they could be the improvement advisor. This person is a subject matter expert on QI, and they provide a valuable insight on the processes of quality improvement perspective. And the last two ones are the QI team members, which ensure individuals from the point of care who are most familiar with the process are included. And then lastly is either a member, a patient, client, or family member involved in the QI project. I find that with my experience with my other QI projects, that when you have a client or a family member involved, it really gives a richness to the project and makes sure that the project is speaking from the narrative of the client perspective, and they do tend to add a lot of value.
Great, thank you, Anna. So with that in mind, we can take another look back at our Live Well Recovery Services example that we shared at the outset, and think about who might play those roles with respect to our example. So we think about that executive sponsor role, that person who's in a position of authority, who can support and help resource the team and remove barriers that may come up. In our case, the executive sponsor is the executive director of the organization. When we think about the quality improvement team lead, this being the person who's really going to be driving this project forward, that has some leadership, but also very familiar with the process that we're looking to improve. In our case, that would be the program manager of the intensive case management program at LiveWell Recovery Services. And when we think about the process owner, that's the person with the skin in the game who's going to be seeing this improvement through after the project, somebody who's very familiar with the process, who lives it all the time. And in our case, that would be the LiveWell intake team staff lead. So somebody who's right in the thick of it. And when we think about an improvement advisor, that's somebody who's maybe not coming to all the meetings, who's really not as familiar with the details of the project, but somebody with some QI expertise, maybe some data expertise, who can support the team as they go through the model for improvement. And in our example, that improvement advisor is the data decision support staff who have done some QI work in the past. We also want to make sure that we have a fulsome team. So other members have been included from other programs, such as case manager. We have an intake team worker, and we have a receptionist. All folks who are part of that project and part of that process that we're trying to improve. And as Anna mentioned, it's very important, if we can, to include clients and family members as members of the improvement team, because as she very articulately noted, it offers a richness to the experience and to the project. And in our case, we have one long-term client of the intensive case management program who's going to participate, as well as one new family member of a client accessing the program. So really two different perspectives, both very valuable for our project. And our total number of team members is 8 people on this team. And we want to keep it somewhere around that. We don't want teams to get too huge where it becomes unmanageable. We also need it big enough that the workload is going to be shared and momentum will be generated. And we'll have another look at our example of our project charter, which Anna walked us through. And you can see now we've got that left side filled in with our team members, so that it's clear for anybody who picks up that charter, wondering what it is that we're tackling. They can easily see who are the main folks on there and what are their different roles. It's also worth noting that there are some aspects that can be particularly helpful when thinking of a high-functioning team. And this is out of some research that was done through the IDEAS program and the Northern Ontario School of Medicine, looking at those teams that function particularly well. What are some of those key ingredients that they have? And what they found was that teams that had a shared goal, so everybody knew what that goal was, and they were all supportive and part of that goal, which was very important. Respectful communication is very important as well within a team. And engagement of team members. Wanting to make sure that everybody's included in a meaningful way and that the project isn't solely driven by 1 or 2 members of the team, but that everybody has an opportunity to contribute and take on some of the work and make sure that their voice is heard. Clear work assignments and clear roles that are reviewed regularly. That's also very important. And that speaks to making sure that we do have those roles that Anna mentioned filled out in our team, that we have an executive sponsor, project lead, etc., and that folks are familiar with what those roles include. Opportunities to get to know the team members is important. Building that camaraderie, that relationship, and that's very valuable. Issues and conflicts are confronted and addressed as they arise, not letting things fester and become a problem down the road. Also having an effective decision-making method, and the team knows how and who is involved in decisions. That's very important. Not just having decisions made by one person without consultation or without a process. That can be very frustrating So making sure to have an effective decision-making method. And that team members establish team norms together rather than being dictated. And opportunities for team members to learn continuously. We're all on a learning journey, especially in quality improvement. That's really what it's all about, and wanting to make sure that all team members have that opportunity. Similarly, some work that had been done by the National Interprofessional Collaboration and Competencies folks, looking at common interprofessional teamwork challenges and solutions. Some of the common ones are listed here. And so one challenge that comes up quite a bit is information not delivered across professions, programs, organizations, and sectors. So a challenge around communication. And solutions to this can include things like communication tools, practices, and meetings, and documentation of what happens within those meetings. Another common challenge is roles or scope of practice related to quality are not clearly defined or understood. That speaks to the challenge of role clarity. And some solutions can be use of structured quality improvement tools and process, such as process mapping, to discuss roles and define roles, and shadowing and interviewing of team members. Another common challenge is lack of focus on team processes, including debriefing on team outcomes. And that speaks to a team functioning challenge. And some possible solutions include team rounding structures, defined team rooms with strong facilitators for meetings, so that the team is meeting and functioning in a productive way. Another common challenge is lack of coordinated care planning or shared decision making. We mentioned that earlier as well. And that speaks to a challenge of collaborative leadership. And we really want collaborative leadership in quality improvement. It's about working together on that common goal. And a solution, or some solutions there, can be shared decision-making trees, so having a process in place that everyone's familiar with and come up with together. Collaborative solutions with team input, and encouraging everybody to be part of that process, and having a process that everyone is aware of and following. And lastly, a challenge around conflict, which unfortunately can show its ugly head from time to time. And the challenge is power or hierarchy with damaged professional relationships. And that speaks to not having a formal conflict engagement strategies and or resolution models. We'd encourage you to think about that when setting up a team. Maybe it's worth having documented conflict resolution strategies, as well as a team agreement that all folks are coming to around behavior, communication, decision-making, that kind of thing, so that everybody's starting out on the same page and understanding the expectations and processes. And remember, having a shared vision is very important. It's important to involve those who are close to the program area where the improvement is taking place. Can't stress that enough. Those are the people who understand and know best. Each team member has an important role within the team and contributes equally to the project. And leadership should empower team members to share in shaping the direction of the project and in decision making. We really want to encourage everybody to be part, an active part of that process. And communication is very important. And Anna also mentioned the importance of striving to include clients and family members, persons with lived experience on our quality improvement teams. And there's some very helpful resources out there that can help you think about how you may want to do that for your quality improvement project. One of them that's linked to this slide deck here is in Patient Engagement Tools and Resources page on Health Quality Ontario's website. And it can be very helpful, very practical. E-QIP also led a webinar looking at and talking to folks about how clients and family members can be engaged in quality improvement. And that link is in this deck as well. And it is on the E-QIP webpage. So that brings us to the conclusion of our first Quick QI webinar. And if you have any questions or ideas, feedback that you'd like to share with us, please reach out to either myself, Michael Dunn, my colleague Debbie Bang, or Jenna Hitchcox, who's our program manager. You're also welcome to join our mailing list by visiting that URL on the right of your screen and keep up to date on all the exciting eQuip news and happenings so that you don't miss out on anything. Thank you very much, and we'll see you next time on our second installment of Quick QI.